President for St. Joseph London, and thank you for the opportunity to really work together with the community to raise awareness on how we are all working as a community to deal with this pandemic. Very similar to other hospitals throughout our area and throughout the nation, we have once again seen a spike with the Delta variant, a little different than we saw the beginning of the year or when this pandemic first started. This surge of the pandemic has been different. Our patients are younger than when we initially saw. Significant increase in hospitalizations, particularly those in age 40 to 50. 95% of those that have been hospitalized are unvaccinated. We have, as a facility, been working very cooperatively internally. From the very beginning of the pandemic 18 months ago, we put in place a surge plan and have been working off that surge plan continuously throughout the pandemic. It has provided the framework that we've needed to deal with staffing, necessary resources. Internally, we have, as we do even before the pandemic, we start out our day with a daily safety huddle. And during that huddle, we review census, we review the status of our patients, ventilator needs, resources, and so on. We have a weekly meeting to discuss specific COVID situations, where we are, any adjustments that we need to make. And that has been very helpful as we have managed through the pandemic. For example, throughout the pandemic, we have adjusted visiting hours, which we have done once again this week, given that at this point, the patient census of the total patients, about 50 to 60% of our census is accounted for by COVID positive patients. We have also seen an increase in visits to our emergency department. That has been for a couple of reasons. Yes, the usual patients that present at the emergency department, but also patients with COVID symptoms, and also for the REGEN-COV antibody treatments that we are also offering in our hospital. Our staff has done a phenomenal job. When we have had challenges with accommodating patients, it has been due to a staffing challenge. We have put several programs in place through crisis pay, bonus pay, pandemic pay, to try to use our own folks, our staff, to manage our patient census. We have had to rely on some agency, but as most hospitals have seen throughout the country, a significant increase in agency cost. So we have tried again to put programs in place locally so that we can use our staff to manage through the pandemic. So that's pretty much a nutshell of what's happening here in London, and I'm sure that Dr. Stanko will address on the more clinical areas once we get to have her speak. Thank you.
All right, and up next is Anthony Powers.
Thank you. My name is Anthony Powers. I'm the president and CEO at Baptist Health Corbin. I'll try not to repeat exactly what John said, but we have done pretty much the same thing. 18 months ago, we started planning for a surge. We had continued using that as the framework as we had moved through the pandemic. Luckily, the first few waves, we really had not got very deep into our surge planning. Unlike the last 6 weeks, we have really got to use our surge plan, unfortunately, and have had to implement almost every step of our surge plan that we created 18 months ago. Like St. Joe, London, we have restricted visitors. And then on the 23rd of August, we actually made the decision, a very difficult decision. We love to have visitors here, but we felt it was in their best interest not to be in the building, because at that time we had been forced to put COVID positive patients in areas that typically were not designed for that. And so we had crash carts and equipment and things that could be dangerous to visitors. So we opted to go to no visitation at that time. We also, on August the 23rd, decided that we were at a point in our surge planning that we needed the staff from our OR. Much earlier, we had made the decision to limit inpatient surgeries as much as possible. All elective non-emergent surgeries had been removed from the schedule or postponed early in August. On the 23rd of August, we made the difficult decision to postpone all elective surgeries and really go to urgent emergent surgeries only. Primarily, we needed the space and also the staff from that area to support the patients up on the floors. Much like St. Joe London, we are running about 50 or 60% of our total census volume is COVID positive patients. Much like John mentioned, this round is quite different. The patients seem to be sicker and they're definitely younger. So we are seeing patients that range from their mid to high 20s in intensive care up into their early to mid 50s. Account for most of those patients, unlike the first waves we saw, which was much older. These patients, because they are so young, tend to stay in their intensive care for a long time, and the outcomes have been pretty grave for several of them, even with young ages. It is encouraging to see that most of the patients in our hospital are unvaccinated, so the vaccine is working. We do have about 94% of our patients are unvaccinated that are in the hospital today. We continue, as John, staffing continues to be a challenge. We have really done multiple things and multiple steps to increase pay, incentive pay. Just can't say enough about the resilience and tireless effort and work that our staff have given, our physicians, our nurses, our housekeeping staff. There's really not an area of this building that have not been affected by the COVID crisis. Materials management, they're trying to get discontinued items and find sub items, and so it really has affected our entire community. We have seen an increase in our emergency department, much like St. Joe London. I'm very happy to say that we have been able to work very closely together to try to if they're surging in their emergency department and need to go on diversion, they work very close with us, and we try to do the same with them. And that's really worked very good to make the best of a very difficult situation. Currently, we are doing the Regenicon infusions. We're doing about 35 or 40 of those a day. We are tapping out of our medication as the treatment is kind of the top end of the barrier, but we are seeing very good outcomes with that. And so that's a very positive thing. So that is kind of the current status of Baptist Health Corbin. At this time, I'll turn it over to Dr. David Worthy.
Morning, my name is Dr. David Worthy. I'm the Chief Medical Officer here at Baptist Health Corbin. One of the things about this particular spike is that the Delta variant is much more contagious, particularly for those who are unvaccinated, far more contagious. And so this spike, what we've seen is a much more rapid rise in the cases and a much greater broad-based infection, so a much greater peak. Last time, the original kind of wave that we had, we were peaking with patients in the hospitals and maybe 30, 35. We've had as high as 74 patients in our hospital with COVID. And that's really, I think the major point I'd like to get across is really overwhelmed, not only our hospital and our staff and really taking us to the brink, but the entire system. So what that looks like is ERs that have very long waits where patients have a difficult time being transferred. I personally spent 4 hours on the phone Tuesday morning trying to find an ICU bed for one patient. Called hospitals in Indiana, Ohio, as far away as University of Pittsburgh, and was able to find one bed for one ICU patient. I've never seen that situation before. And every place that I called basically said the same thing. We're overwhelmed also. We have no ICU beds. And that's been the most dramatic effect at our hospital. I think most hospitals across the country, or at least this part of the country that experienced this surge. So we're seeing Our patients have a difficult time being transferred to higher levels of care, far longer waits than what we're used to, up to 80 hours sometimes. We've had to expand our ICU capabilities. We have a 10-bed ICU here in our hospital, and we've had as many as 19 patients on ventilators, which normally we keep in our ICU. And we've had to expand the capability for critical care beds to another 10 beds. And of course, we've had to take those beds and expand those to the next level of care, which for us is progressive care. So we're seeing very sick patients because of this, and because we are really staffed to kind of just function at a different level than what we're seeing. We've had to shut down other services. So as Anthony's mentioned, we've closed our surgery except to emergency cases. We've closed our cath lab except to urgent and emergency cases. We have shunted our RNs from support positions, from quality, from our IT services to case management. And we brought all these RNs up to the floor to augment our RNs that are used to working in these places. And because of that, we've been able to safely care for our patients that are typically in the ICU. We have also started the Regeneron clinics, like Anthony said, very important, because we know when people who are symptomatic and sick with COVID, but not sick enough to be in the hospital, when they receive that can prevent them from coming to the hospital and prevent them from getting on ventilators and even dying. So that's very important work. We've also expanded our vaccines, which is very important. We are seeing the vast majority of our cases, like the rest of the country, are unvaccinated. It's about a 15-fold higher risk of getting COVID and getting sick enough to be hospitalized or on the ventilator if you're unvaccinated. And that's the numbers we're seeing, somewhere between 15 and 20%, or 15 and 20 times higher risk if you're unvaccinated. And we are seeing much younger patients into the 20s. And that's been really difficult for our staff, for our physicians, for our nurses, because we're seeing patients that we know that that are our friends that have 2 and 3 children that are now on ventilators that we're having very difficult conversations with. It's really taking a very difficult toll emotionally on our staff. And we've had to support that with our chaplains and some behavioral health people. And I'm very, very proud of our staff. They've pulled together. They're doing amazing work, but they're fatigued. They're tired. So we need our community to do what they can do, which is, number one, get vaccinated if they haven't. It's very safe. If you look at the profile and the side effects of having a severe reaction to the vaccine, it's actually a lot safer than penicillin. These are safe, and they're very effective. The other thing is, wear masks when you go out, particularly if you're indoors in large gatherings. But if you're in public places, please wear a mask. They do work. We need all hands on deck to prevent our system from being more overwhelmed. I would say it's on the brink. The hospitals are doing the best they can. They're surviving, but there's really not much more capacity. So we need everybody doing their part. Thank you.
My name is Shelley Stanko. I'm the Chief Medical Officer for St. Joseph London, and I'm a practicing family physician. So have had an interesting experience of caring for patients as we've also administratively been trying to help out the hospital. London's my hometown, so it's very near and dear, this whole area, to making certain that we can provide the very best care possible. And we find ourselves on the edge of that. And that's really the message for today. I think that John and Anthony and David have really expressed that extremely well. For myself, I would emphasize how incredible the cooperation of community has been around all of this work. Much like what David talked about, St. Joseph London went from 14 ICU beds to 24 ICU beds. There weren't magically nurses falling from the sky. Our chief nursing officer and all of our nurse leaders, one of whom is Kelly, you're going to hear from, worked together to figure out how do we do that safely. We've called on our outpatient practices. We've said nurses that have been working in offices or medical assistants can be helping hands, can help decompress some of the tasks so that our very smart and good nurses can still take safe care of patients, even when we're asking more and more of them. Yes, there's definitely been times of agency, and we are grateful for when we can find them, but that's a shortage across the nation as well. We've expanded and expanded, as has Corbin, and now we find ourselves at the edge of what we can do. Vaccination, it is the strongest tool that we can use. I would echo what everyone has said about how much better consistently we see people do when they do have to be in the hospital, but they've been vaccinated. It's the difference of the person who teetered at the edge but did not need the ventilator, who had risk factors that would say they might not have a high survival rate, but they have, and they're improving and they're getting better, versus the person who is unvaccinated and unfortunately continues to struggle and to progress and to decline despite being offered every possible medical treatment. I would emphasize the Regenkov Clinic. It's a wonderful tool. It is available. Baptist is doing a great job with that in Corbin. We are doing that at our hospital as well. And if patients will seek care from their family physicians sooner rather than later, and by all means, let us assess and see if this is a tool that could be used. I would really encourage people. I think I'd have to echo, though, what Dr. Worthy said. Medications are one of those scarce resources. We are only allotted so many doses. So it's not really a total answer, but it is certainly a good tool to use. Masking is critical. It's not all that hard. I have kids. They're just accustomed to me saying, do you have your mask? It's the question we ask each other as we get out of the car every single day. Did you remember a mask? Do you have an extra one in case you spill something on the one that you took with you? It's very effective, and it is one more tool that is easy to use. It doesn't take a medical degree or special training to make that be effective. It's been harder and harder for staff to rally around and to support one another. The emotional, the physical, the spiritual fatigue is very real. Echoing what Dr. Worthy said, the support of each other, the support of our chaplains, of our ethics leaders has been critical in this time. I would also emphasize that it is not one hospital standing alone. We are part of larger systems, but as such, we are also experiencing the strain all of the system hospitals are going through. Normally, we have some ability to offload a little bit of that pressure when things are tough, but right now, everyone's at that place. I spoke with a hospitalist. He had called 37 hospitals trying to find treatment for one single patient. That was on top of a significant load of very ill patients that he needed to care for that day. Even as we step in, as Dr. Worthy said, and we try to help make some of those phone calls, those are hours of the day that can't be spent doing other tasks to help patients, and recognizing how scarce that resource is. Lots of patients are having to spend extensive amount of times in the emergency department. Whether it's they're admitted, they need to be in the hospital, we're going to do everything we can to take care of them, but there is physically no space for them to leave the ER. That then makes it harder for the next ER patient to find a spot to get into. It involves, initially seeing people in waiting rooms and things that are really different than how we normally like to practice medicine. But we've recognized this crisis time calls for crisis management. Our ask right now of the community is we're absolutely going to continue to do our part. We are going to continue to be here, and we're going to continue to take care of everyone that we possibly can. But every opportunity you can take to help us is going to make a huge difference for your own family, for yourself, and for your community.
I'm Kelly Helton. I'm the Director of Critical Care here at St. Joseph London. I have my mask on because Dr. Blair and I are sitting so close together. So I sort of apologize for that. But so here at St. Joseph London, we have seen over the last 18, 20 months a need to double our capacity of ICU beds. Thankfully for us, we had a unit next door adjacent to the ICU that we were able to expand out for an additional 10 beds on that adjacent unit. Since we have seen such an increase in our COVID admissions, currently here at St. Joseph London, as of this morning, 87% of our ICU population is COVID positive. 0% of those are vaccinated. I did chart reviews this morning to just make sure. And we do assess vaccine status upon admission in our nursing assessments, and 0% of the ICU patients here at St. Joseph London are vaccinated. And so I think that is, it speaks volumes to what we're dealing with here. These patients are very critical. 88% of what we have currently are on life support. And it is a very heavy burden for us to bear. These patients are sick, they are young, they are our community members, our church members, our family members, of people we love. And it's very hard. As a nursing leader, you know, the moral distress of this for both myself and the staff that are caring for these patients, it's huge. It's heavy. And, you know, there are tears. Most ICU nurses, they don't cry a lot, but we have tears daily because of what we're seeing in these patients and how sick they are and just the circumstances around it. You know, they're begging us not to let them die. They're asking us, you know, can I get a vaccine? You know, unfortunately, when you're in the ICU and you're requiring mechanical ventilation, it's too late to be vaccinated. You know, we're all wearing our mask and walking into these rooms, and you know, they can't see our faces. We're having to have conversations with families, you know, via FaceTime and just to let families see their loved ones before, you know, they go on the ventilator or on the breathing machine. Again, we love what we do. We are happy to provide this service for our communities. We love the patients we serve. We are just morally distressed at this point in time with the volume of the patients and the care that we're having to provide.
I'm Dr. Catherine Blair. I'm actually the Director of Critical Care here at St. Joseph London, and I am a general surgeon by training. And as we've heard from everyone, elective surgeries have, of course, been postponed at this point. And one of the ways that my partners and I have decided to help out is we are actually taking over management of the ICU patients, kind of stepping into a hospitalist role with surgeons, you know, so we can be here readily available to help with procedures and support, especially with our pulmonologists who are clearly been overworked with this 18 to 20 months that we've been dealing with this COVID pandemic. So, you know, as everyone said, everyone's, you know, stepping out of their roles to try to help in kind of these crisis management. And this is one of the ways that as general surgeons, we get a lot of critical care training in our training. And so we felt this was a way we could step in and help out by helping manage these ICU patients, especially since, you know, the hospitalists are having to call multiple facilities and things like that. And, you know, Dr. Stanko brought up the point that they are wasting time on the phone trying to utilize resources elsewhere. You know, we're able, by us helping out in the ICU, we're trying to help free up the hospitals to take better care of the patients they have on the floors and in our progressive units.
Good morning. I'm Josh Bowling. I'm the pharmacy manager at Baptist Health Corbin. I'm going to talk a little bit about the vaccine. There are currently 3 vaccines that are authorized or approved by the FDA here in the United States. 2 of those are mRNA vaccines, the Pfizer and Moderna vaccines. Just a little bit about those vaccines. The mRNA technology has actually been around since the 90s when they first started studying it. We actually also studied mRNA technology for vaccines in previous coronaviruses, such as SARS in the early 2000s and MERS as early as 2012. So as far as the mRNA technology, the COVID-19 vaccine is the first vaccine to use that technology, but it has been extensively studied for a long time. The J&J vaccine is a viral vector vaccine, which is actually that type of technology has been studied around for 50 years. As previous mentions by the previous panelists, it has been these vaccines are virtually safe and very effective. When you talk about the few cases that they've had of like myocarditis or clots. That has been very few when you consider that worldwide we have given now over 5.6 billion doses, and that's, like I say, billion with a B. So that's a lot of doses. And currently we are administering about 32 million doses worldwide per day. Most side effects, if you get any, would be acute side effects that happen about 24 hours after the vaccine. And these are not necessarily a bad thing. The vaccine is given to elicit an immune response, and signs of an immune response could be fever, muscle aches, chills, fatigue. That virtually means that the vaccine has done what it's supposed to do. It has elicited an immune response, and those side effects typically only last 24 to 48 hours after that. As far as to echo what everyone else has said, that the data showing for the state of Kentucky that if you are unvaccinated, you are about 10 times more likely to get COVID. You are 41 times more likely to be hospitalized from COVID, and you're 23 more times to die from COVID if you are unvaccinated. So thus, with vaccination, you are at a much lower risk for infection, hospitalization, and death. The biggest question I think I get about the vaccine is they feel like that it was rushed, or the FDA, such as the Pfizer vaccine that's FDA approved, that it was rushed for approval. And just to kind of explain some of that, Pfizer actually submitted their FDA application for approval on May the 7th, and it did not get approved until late last month. So really, when for the FDA to review all of their data to submit, it took them over 3 months, which to me, I would say they didn't approve it fast enough, that they should have had the resources to try to upspeed that approval. Currently, we get a lot of questions about the third dose. Currently authorized by the FDA for just the mRNA vaccines, which is Pfizer and Moderna. There is a third dose that is authorized, but it's only for those with severe immunocompromised conditions, such as those undergoing active treatment for cancer, recipients of a solid organ transplant, those that have advanced or untreated HIV, or those that are on medications that cause you to be immunocompromised, such as Humira, Enbrel, or high-dose steroids. The reason for that is indicated 28 days after the second dose, and the reason for that is because 2 doses in that patient population does not stimulate enough of an immune response. They are currently evaluating, the FDA is currently evaluating the literature for a booster shot, which is a third dose for most of the general population. It is projected that the Pfizer one will get that authorization by September 20.
Good morning. My name is Philip Johnson. I am the recently retired chaplain manager from Baptist Health in Corbin. And hey, Anthony. Hey, David. And I want to thank Mary and Tamara for the opportunity to share just a few thoughts this morning with you all. As a chaplain, I have lived with death every day. I have seen the multiple faces of COVID over these past 18 months. It's not been pretty at all. And by multiple faces, I mean I work with staff, I work with patients, COVID patients virtually, families, pastors. It's difficult seeing local pastors suffering from COVID. I've seen them as patients, as my patients in the hospital. Pastors who may not have been huge mask advocates and ended up in a hospital bed, maybe in the critical care unit or PCU, dealing with anxiety, because I've seen it on their face during those visits. And as I've had prayer with them, I know they're struggling. And I see the struggle that they're going through, maybe in their head and in their heart over this. My last day at the hospital was probably the epitome of COVID for me. I was on call the night before, and I was called in a difficult situation, a patient really too young to die, had children at home. There was so much going on, so much going on. I got home late. I was called back the next morning at 5 a.m. on my last day of work. I will probably always remember that day because so many things were going on. We had staff who were dealing with these feelings, yes, of moral distress, like Kelly mentioned, compassion fatigue, physical exhaustion, but also anger. I picked up anger in the voices of some of the nurses I spoke with. Anger over unvaccinated patients who end up taking beds that should have gone to other patients. So yes, it was personal to them. And it was hard for them to navigate those waters as they were caring for their patients because they were nurses. And nurses practice deep, loving care. And then dealing with the family of the patient that would soon pass away. I've seen personally, right up front, patients bargaining with doctors and with God, expressing guilt, regret, remorse over something they couldn't change, that they were powerless against, and their faith was coming into question. I've seen them say, "Doctor, I will donate an organ for my loved one. Please, please." And having to hear a doctor say, "I'm sorry, your loved one is not a candidate, not at this point." And then that changing to, "I should have done something. I should have gone to them when I could months ago. I should have asked them to get vaccinated. I should have encouraged them. I should have demanded." And knowing that they were powerless against this. And I saw families weeping and crying, wailing, and doctors who felt so helpless, who had done everything they could. And all that was facing this family now was a certain death of their loved one. I've seen that. I've seen that up front and personal, and that is hard to take. So let me put it like this. I firmly believe that the vaccine is a gift from God. I mean that. I absolutely mean that from the bottom of my heart. The vaccine is a gift from God. I believe all those years of research at the CDC and all those other places, all those years of research into something paid off. And they were able to get together a vaccine that eventually got FDA approved. They were able to get it together in a matter of months. That vaccine has been given to us. I got mine on December the 19th. I'll never forget that because I know that my stress level began to come down. But I continued to wear my mask and wash my hands and socially distance and do the right things. Why? Because it was more than just a vaccine for me. My faith came into it. And as a person who is of the Christian faith, I see that this is something that comes with scriptural backing, to love my neighbor as I love myself. It's not just about me. It's about me loving my neighbor. So I can't say my body, my choice. I can't say, if it's my time to go, it's my time. God knew. I can't approach it that way because I have a personal responsibility to my community and to my loved ones. And that begins with vaccination. That's how I show my love for my family, my fellow hospital workers, my neighbors, my church. And so I just want to finish by saying that of all people in our community, probably pastors and religious leaders need to be the very first out front, even ahead of our doctors, ahead of our healthcare workers. They need to be the ones because they need to be the ones. They're the ones who have touch with people on a grassroots level on a weekly basis. They have authority, they have leadership, and they can influence this and they can turn the tide. So I'm reaching out to you as spiritual leaders in our community today to say, do your part. Do your part. Scripture backs that. Check out the first part of Romans chapter 15. you'll see that there's a New Testament church that it was all about pulling together. And they were an oppressed church, and they pulled together during times of strife and during times of tremendous adversity. They didn't have COVID. We do. But we have their example from many, many years ago of a people who pulled together in Christian love. They had a mandate from God to take care of each other. And I hope that we will take that seriously as well. Thank you for the opportunity to share.
Thank you. All of that was so important to share with media. And again, for the media members with us today for this press conference, if you have questions, put that into the chat. I'm going to begin asking some of the questions that have come in so far. We're going to start with WYMT. This one is for President Powers. What will the conditions in the hospital need to be like to allow visitation again?
Thank you for the question. That's a great question. As soon as we can get our ICU patients back into the normal location, we will feel like we can open up visitation again. We're currently making, some accommodations for end of life, birthing mothers, those kind of things. But right now, until we can get the ICU back into its normal facility and geography, and not scattered down in other areas, we'll continue with the no visitation. So we're hopeful. We feel visitation is very, very, very important. It's great for the patients, good for the staff, good for the families. But right now, it's just not safe. So we're watching it every day. As soon as we see that decline, we'll open the doors back up.
And the same question for President Yanes. I know there's been a lot of change in visitation policy for St. Joseph London as well. So the same question, what will the conditions in the hospital need to be like to go back to something a little bit more normal?
And again, throughout the pandemic, we have monitored and adjusted our visitation policy. As Anthony mentioned, we have to get to a point where we feel it's safe. It's safe for our patients. It's safe for our staff and our community. Again, keeping our staff healthy is absolutely essential at this point. As it stands right now, we allow visitation from 7:30 to 5 o'clock with one designated individual. In our obstetrics, we do allow one visitor for 24 hours. The emergency department currently is no visitation. And for our outpatient patients that may be coming in that need assistance, physical assistance, we do take that into consideration. So again, we're monitoring day by day, and that's where it stands right now. And when we get to a point where we feel comfortable that it's safe to adjust that, we will again, and certainly communicate that through social media and our webpage.
Okay. Great, thank you. The next question coming in is from the Courier Journal. So I'm going to ask this one to Dr. Worthy. They are interested, and then we'll go to Dr. Stanko as well, but they are interested in hearing more about the Regeneron clinics and the process for knowing who to treat, letting patients know about that option. So if you would like to begin, Dr. Worthy.
Well, first of all, let me say, echo what others have said, that the Regeneron is a real key strategy and helping patients stay out of the hospital, and overwhelming hospitals stay off ventilators and not dying. It's got good evidence. I believe the relative risk reduction is about 70% for those events happening. So it is good. The people that are candidates for that right now are those that are symptomatic, so they're actually sick from COVID, but not sick enough that they require to be in hospitalization. So they don't require supplemental oxygen, for instance, or if they're on oxygen, they don't require a higher dose. There's also some other things related to age, to obesity, to other types of illnesses they may have, immunocompromised folks. So it's really kind of a high risk stratified in terms of who has the most benefit from it. It can be used to prevent someone who's had contact, but really, I think most commonly it's being used for those people that present to their physician's office that are sick, but not sick enough to be in the hospitalized. At our hospital, we have a simple form that the physician can order that, fax that in, we call them back. We're doing up to 35 to 40 treatments a day. Right now, we're doing the IV infusion, It has been improved to be given under the skin in actually 4 different spots. And we're hoping that we're going to get some support from the state to stand up some regional clinics where we can have kind of mass use of this, where it can really be scaled up. So that I know that's going on right now with some conversations at the state level. But it's an important piece of the armamentarium. It really does require physicians order it this part. We tried to make that as painless and frictionless as possible. And I think London's doing something very similar. So.
Yes, I would echo most of what Dr. Worthy said. We do have a protocol. We are doing it through a clinic that's adjacent to the emergency department. And so outpatient providers are able to contact the emergency department, and then we take it from there with the protocol. Emphasizing it is for those highest risk individuals. That's based on the emergency use authorization for this medication, because that's what it functions under. We've seen excellent results. Right now, we are infusing basically all the doses that we're able to get, not in abundance, but it is a good number, and I do think it's making a significant difference.
All right, thank you both. The next question is coming in from the News Journal. This one is for President Powers. Baptist Health Corbin's surge plan was developed 18 months ago. What was that plan, and how has that plan changed or been adapted, if at all?
Thank you, Tamara. The plan was developed 18 months ago. It continues to be refined almost every day now. But basically, we started internal. We looked at our internal resources, how many patients we could house, where we could house them at, where we could overflow ventilators at. And then we looked external, what kind of resources can we get from our system and from the open market for additional ventilators and equipment, and just scaled up by the number of patients that we would receive. Luckily, up until this wave, we really never got much past kind of a second stage of our surge plan. This time we're nearing the end of our surge plan. We're really to the point that we have almost tapped out all of our resources here at our hospital. And so I really appreciate all the physicians on this panel and Philip and everyone, encouraging everyone to get their vaccine, social distancing and masking. It's the one thing we can do. If you love a healthcare worker, doctor, nurse, anybody that works in healthcare, I really urge you to do that. We have command center calls, Tamara, twice a day now during this peak. So we do it at 9 o'clock and at 1:30 every day, and look at our resources, our staffing, our total number of ventilated patients, kind of where we are now, and then how do we get through the next 24 hours. So it really is, at this point, we're just trying to get through 24 hours at a time.
Great. And to follow up on that, President Yanes, is there anything you would like to say about the surge plan for St. Joseph London?
Very similar to what Anthony outlined. And initially it was what is capacity and what resources do we need to achieve that? Variations from that. And again, throughout the pandemic, we have modified that with a lot of coordination with community resources, others facilities such as Baptist Corbin, and internally within Lexington, with a primary focus on staff and also PPE and the necessary equipment to support patients that are on life support.
The next question is from the Courier Journal. So whoever would like to go first on this one, the question is, do the patients often ask about vaccines in the ICU? Actually, this is for Kelly Helton, sorry about that. So Kelly, do the patients often ask about vaccines in the ICU? Is it more common than not?
So they ask about it some. I'm going to say it's probably not as common as we wish it would be. However, once they test positive, it's too late to be vaccinated. And so we have to let the virus run its course, and then we will vaccinate them, hopefully after they are discharged out of the hospital, after their 3-month window of treatment.
And did Baptist Corbin want to address that question as well?
Yeah, I think we do occasionally see, that question asked, but again, just to echo what others said, it's too late. It's really a question of desperation. Will it help me? I'm willing to take it now, but it's too late. So it does come up, but at that point, it's not the right treatment.
The next question is coming in from the Herald Leader. What is the trend in cases over the last 2 weeks? Up, down, steady? What is the projection over the next couple of weeks if that is known? I'm going to start with Dr. Stanko for that one.
Thank you. So one of my other hats that I wear is the medical director of the Laurel County Health Department. So staying in constant contact with the public health scene and also reviewing the state data. So from a state perspective, last week was the highest week that we've seen in the pandemic so far. As you look at the positivity rates for the counties that are served by both Baptist Health Corbin and by St. Joseph London, those positivity rates have continued to increase. The latest data is an additional increase in all of those counties. The actual rate of increase, I do think, has slowed a bit. Often, when you speak with the epidemiologists and the statisticians, that slowing indicates maybe we're getting close to peaking on our numbers of cases. An important point to make, though, is that once the cases peak, we still have about 3 to 4 weeks out for hospitalizations to peak, and that's based on the course of the illness. So right now, we've not seen a decline in total case numbers, and we certainly haven't seen a decline in hospitalizations.
And then Dr. Worthy or President Powers, did you want to speak to that for Baptist Corbin?
Yeah, I think it's the same thing. If you look at the models, we've been following the Kentucky models, KHA, some of the other ones. It's thought it's going to peak. Now, they have predicted models, they have bad outcomes, they have lower ones, but if we stay in what they actually predict, we're probably going to be peaking with total number of cases in the community probably this week, maybe early next week. Somewhere around there is the kind of the odds-on favorite. But the key point is exactly what Dr. Stanko made, that you don't see a peak in hospitalizations until about 7 to 10 days after that peak. And then you don't see a peak into ICU and the ventilators 10 days after that, so 17, 20 days. So we are not over this at the hospitals. I still think we're going to see more and may have a peak in the hospitals yet to come that will be delayed. But if the models hold and if they're true and if they're accurate, then overall cases, we're hoping to peak out sometime within this week, but time will tell.
The next question is from the Mountain Advocate. We'll start with Baptist Corbin with this question. Have there been issues with patients coming in after self-treating with ivermectin or other such treatments?
Well, unfortunately, there are some providers I'm aware of in the area that have been proponents of that. We have had patients, I can tell you for sure, we've had a couple of patients really requesting / demanding to be treated with ivermectin in the hospital. Looked at the data, ivermectin in a petri dish in a lab looks like it's effective against viruses. But anytime it's been studied in real people in real life, the data is not very convincing at all. So I do think there should be some more long-term studies of that to see if it actually pans out. But there is no data right now that says it is a worthwhile treatment. And unfortunately, people are hanging their hooks on any area of hope that they can get. So yeah, we are seeing people request that when they get to the hospital. We're seeing some providers in the area that are prescribing that. I think that there's no data to support that. And we are not prescribing that in our facilities as a system, a Baptist health system.
St. Joseph London.
Yeah, I would echo most of what Dr. Worthy said. We have definitely seen some patients who have made the decision to self-treat, or as he indicated, some providers who are using some alternative treatments, whether it's the ivermectin or hydroxychloroquine, suffering side effects. We have not had any full toxicities, gratefully, but that is certainly a risk. So I would really echo his statements. The research doesn't support that this is a good idea, and we certainly have some better options to use, and so would really encourage persons to seek more appropriate and evidence-based treatment.
And then the last question we have in the chat right now is from WYMT. Dr. Stanko, I'll start with you on this one. Is there any sign the Regeneron supply could increase and more people could receive it?
So at this point, there are regular shipments of the medication. It's not absent. It's more about timing and how quickly it can be spread out because, of course, everyone across the whole country needs it, right? I think that some of what Dr. Worthy referenced with the state programs, their goal is to try to increase the supply to the state overall. So we would certainly be happy to be able to administer more doses, and we would certainly be happy to figure out how to do that in an efficient manner. I don't have a path at this moment to increase the amount of drug that we get. We've attempted that, but certainly open to trying to work with the KHA and other entities to figure out how we could do that.
And I would also like to hear from Joshua Bowling on that one too before we go to Baptist Corbin.
Yeah, we don't necessarily have an issue with supply. I think we've been doing a steady infusions over time. I think our allocation is based off previous administrations. So our current supply is able to accommodate the patients that we need at this time. I think our biggest barrier to increasing the amount of administrations would be obviously space and then staffing to actually administer those. Because where we are already, deprived of space and staffing due to the surge, we're having to come up with extra staff to staff these clinics and then also find locations to administer these infusions or injections as well.
Thank you. And I should clarify, Joshua is with Baptist Corbin, but Dr. Worthy, did you have anything else to follow up with Joshua?
I think it's a little bit of both. I think overall there's a general undersupply in the state of Kentucky. I think that's a true statement for the need that's out there. But the other one is the ability to scale it up. And it's very labor intensive process doing an IV infusion. You have to set up the IV, there's special filters. You have to have a nurse. It's an infusion of 1 hour. You have to watch them. So it's a very time intensive. And really the way to scale it up, I think, is going to be the subcutaneous, the under the skin injections. Have that at some large offsite area where people can easily come in and get to treatment, where that's resourced with people not from the hospital. We need all hands on deck in our hospital. And I think that's where the state can be very, very helpful. And I'm hopeful. I actually talked to Robert Stivers, the Senate President, this morning about this. I'm very hopeful that we're going to have some regional center that will stand that up because it's very important. So we'll see how that goes, but we need a large scale use of that across the state.
Great. Well, thank you. To all the media members that sent in questions, thank you so much. To all of our participants, the panelists today taking part in this, thank you so much. We do want to remind media, this was live streamed on the St. Joseph London Facebook page. It is also going to be posted to the Baptist Health Corbin Facebook page as well. And we also have this Zoom recording, so we can make that available with you here in a little bit as well. So if you have any questions, please let us know. But thank you all again for joining today.
Thank you.
Thank you.
Recording stopped.